Welcome to the Doc Dudes, your premier podcast for a behind-the-scenes look at the latest in aesthetic medicine. Hosted by the cosmetic surgeons at Graper Harper Cosmetic Surgery in Charlotte, North Carolina, the Doc Dudes brings you interviews with insightful guests, expert tips from experienced medical professionals, and lots of laughs along the way. And now, here's Dr. Garrett Harper and Dr. Evon Zoog, also known as the Doc Dudes.
So welcome to another episode, another podcast of the Doc Dudes. This is Nacho Mama's Makeover. Evan, that just made me hungry. Talk about nachos.
I'm getting hungry at 6 o'clock.
I know, right? Did you and Natalie have a good Valentine's Day?
We did. We went to dinner, had some time for ourselves without the kids.
That's probably the most important thing in a marriage when you've got 4 little ones under the age of 8.
Yeah,
God bless you.
It is hard to do, but we make a point of trying to spend time together.
That's awesome.
Them, so.
Date your wife,
it really
right?
does make a difference.
Date your wife. That's my advice to the listeners out there. Date your spouse. Well, we're going to not talk about nachos. We're going to talk about mommy makeovers. And so, a lot of people have different ideas of what that means. Obviously, mommy makeovers it has to be defined as something. So what does a mommy makeover consist of, Evan?
So typically, after a woman has had kids, she's had some changes to her abdomen and her breasts, and that's what we're addressing with the mommy makeover.
Yeah. So, it's typically been some combination of breast surgery with abdominal surgery, and the degree with which we have to correct things is commensurate with the degree to which the problems arose. And it's not just from pregnancy, right? We do combinations of breast and body for all sorts of things. Think about the massive weight loss patient, right? Like you see a lot of massive weight loss patients. And so similarly, they can have excess skin, they can have contour irregularities with weight gain, weight loss, those types of things. So we may use the term mommy makeover, and you might not be a mommy. So don't take that, we're not saying you look like a previously pregnant person. We're just saying this is what the combination is. And so a combination of breast and body, typically surgically, right? And so let's talk about kind of the individual components to that thing. So let's talk about the breasts.
Yeah.
So I always like to say that we're not the breast police. And so I have my patients bring me wish pics, right? And I also tell patients, if you have some idea of what you want your breasts to look like, and I don't think that's safe, or I don't think I want to put my name with that, there's plenty of plastic surgeons that you could go to that would do that. But
that's one of the most helpful things for me is bring me some pictures.
A picture's worth 1,000 words. Yeah. So when people start talking in cup sizes and bra sizes, that's just so user error prone. You can send somebody to 5 different places to get a bra sized, and they'll come back with 5 different measurements, right? I am a 32 double D at Victoria's Secrets currently. Mm-hmm. So
I think plastic surgeons are, visual learners at heart. That's how we're trained.
The good ones are 100%.
This board process is rough, having to take pictures of everything, but it's part of it.
It gets better. You're almost through it. You're halfway through it, which is great. But yeah, so people come to you with breast surgery. And so talk about a couple of the different breast surgeries. Like if they're too big and they need to be reduced, if they're saggy and they need to be lifted, if they need restored volumes, what are some ways that we can restore lost volume in patients? Some women, come to me and their wish pic is their picture when they were breastfeeding, right? They're like, I felt like when my breast got engorged and I was nursing, that's when I loved my breast the most. You're like, wow. It's just such a consistent thing that people talk about. And so what are the different surgeries for breasts that you come across when you're operating on the Nacho Mama?
Yeah. So, breast reduction. We do lots of breast reductions. We do lots of breast lifts. Yep. We do a lot of breast augmentation with implants. You can augment a breast with your own fat as well. Yep. That can give kind of a more modest improvement in the volume of the breast. not like an implant, but that's an option.
Yeah, and I always felt like I told patients, when you use an implant, we'll go over the safety of that in a second, but when you use an implant, you're getting whatever you use. Like, it's 100%. It's not, you don't have to worry about some of the fat absorbing or any of those things. And you can use, theoretically, whatever kind of volume is made, right? I mean, there's some patients who don't have enough fat or want a big enough change where it would take multiple fat grafting sessions for them to achieve the volume that they wanted for their breasts. So I love implants. I think they're incredibly safe. Technologically, I don't know where we will get them any better, right, with the new gummy bear gel implant. So when somebody comes to you and says, I'd like a saline breast implant, I know what I say to them. What do you say to them when they talk about that?
I tend to educate them on the advantages and disadvantages of both, but I like a silicone implant. I think they're more natural feeling, more natural looking, just overall better.
Yeah, I think they're more durable, and I think that less chance of encapsulation or forming kind of excess scar tissue around the implant, which is great. I also think that the relationship of having complications after breast surgery using an implant is almost in direct correlation with choosing implants that are too big for somebody and that their body just wasn't meant to have. And so I educate my patients a lot on, look, we're about to take a bunch of measurements. I'm a biodimensional breast surgeon, meaning I'm going to take a bunch of measurements and I'm going to listen to those measurements. I'm going to help those measurements guide me and into making decisions that are safe and that have longevity. I joke around about patients. I felt like somebody asked me this the other day, actually over the weekend. Somebody said, do I need to get my implants redone every 10 years? And, I tell patients the 10-year thing kind of came when manufacturers 20 years ago, 30 years ago were looking at things and they'd say, well, at what point does a typical patient have to have revisionary breast surgery? And at what point really do a quarter of patients need a different implant? And they just kind of looked at all the data and they said, well, that's somewhere around 10 years. So 10 years got picked arbitrarily.
And implants have changed a lot since they've made that.
They've changed so much, and also consider that a lot of these patients, are the average age of the first implant is going to be in their 20s. So think about what happens to a woman's breasts from 25 to 35. I mean, you're typically having your kids. And so your breasts get larger and get smaller and kind of go through all those changes. And so it's not the implant's fault. So I tell patients now, I'm like, my goal, no matter what age they are, I don't care if they're 25 or 65, I tell them that they need to understand that this implant should go to the nursing home with them. The gel devices now, the silicone gel devices that I use exclusively, I don't put saline implants in patients. So if they ask for a saline implant, I just like you, educate them and try to tell them the safety profile, how much better the pros and cons, the fact that the saline devices are actually an outer shell of silicone gel. So what their body sees is silicone gel, no matter what. And that if we cut these implants in half now with a samurai sword, they don't ooze. It's not like the consistency of honey or molasses like the implants 6, 7, 8, 9, 10 years ago. We call them gummy bear implants now. So what does gummy bear implant mean for patients out there?
Yeah, so that speaks to the cohesivity of the implant. So if you think of a gummy bear, if you cut a gummy bear in half, you can have two halves of a gummy bear. It's not going to ooze out.
Right. And like a brand new, straight off the conveyor belt, really nice, like Haribo or Black Forest gummy bear. These are not the ones that you find in between your car seats, like the white ones that nobody wants to eat, the white ones, right? Everybody eats the red, everybody eats the orange, but your kid kind of throws the white one off to the side, and then you find it the next Halloween or several Halloweens later, and it feels much better than that. So the new gummy bear gel devices are extremely safe. They come in a whole bunch of different sizes, shapes, profiles, all those things. And so the patient's wish pick is what we use to kind of choose the device that will get them to their goal, right? And that's using an implant to help restore volume that they may have lost as they've aged and as they've had kids. The other kind of component to the breast surgery is going to be redraping potentially their breast envelope, their skin, their nipple, getting those things in the perfect location. And so that's a lift, right?
Right.
And so you can lift in any number of different ways. There's all sorts of different techniques. We tend to use a superior pedicle for our patients here. I do think that it's a superior technique, no pun intended. But when you tell a patient, hey, we're going to use a superior pedicle for your breast lift, what's that mean? Like what?
Yeah, so I kind of, when I'm talking to a patient about breast surgery, I talk about blood supply to the nipple and the areola and how do we preserve that. There's lots of different ways. I think a superior, in the past, an inferior pedicle was a very common way to do a breast lift or a breast reduction.
Yeah, 20 years ago, it's what everybody did.
It's what everyone
Still,
did.
probably 90% of surgeons who were trained on that technique use that technique exclusively. One is because it's applicable to everybody, right? Mm-hmm. Superior pedicle has some limitations anatomically on some, but if you're a candidate for it, by far and away the best. So you're talking about blood supply.
Yeah. So what can happen if, you can lose your nipple, you can lose the blood supply to the nipple and the areola, and it can turn to a scab and fall off. And I tell patients that.
Right.
I'm very blunt with them.
Yeah.
That's the one thing I'm kind of blunt about because I want them to remember that can happen. It's never happened to me, but
right.
I've seen it happen before.
Yeah. And that typically happens when somebody plans poorly, right? Mm-hmm. I mean, a lot of times, we'd love to kind of point fingers and say the patient's anatomy or what, but patients come to us for our expertise. They come to us because we've done this thousands of times and because we're board certified and we've trained at the best places in the country and we've got thousands of patients that we've done this on successfully. A lot of times it's their friend or their neighbor or their family member that we've operated on. I mean, word of mouth is really what drives our industry more than anything. And so these patients have seen our results and they know that we're going to make decisions and plan for their surgery so that they get the best result possible. And so you're right. I mean, think of the number of surgeries that we've done and I've never had that be an issue, which is what's great. Now, 35% of my practice is probably revisionary stuff. And so if it's revisionary stuff, you have to be conscientious of what may have been done before you 20, 30 years ago, right? And so that's where breast surgery gets really difficult in the revisionary cases and why I think you and I both do breast reconstruction for patients that have mastectomies and lose their breasts for cancer purposes. And I think that makes us better cosmetic surgeons. And I think
it starts with the reconstruction.
Yeah, and I think
100%.
And I think doing as much cosmetic surgery as we do on breasts makes us a better reconstructive surgeon too. So I love that I have that balance in my practice, and I know that you do too. But that's the breast component to a mommy makeover, right? The other component, the other side to this is the tummy. And so we've got a bunch of different kind of avenues to go by. So talk about kind of what liposuction is.
Yes, this is one of my kind of things I'm most excited about right now and love doing are tummy tucks and body contouring, abdominal wall contouring. There's lots of parts, but we'll start with liposuction. And,
sure.
Those patients are typically younger and don't have extra skin. But after a woman has children, you can have a separation of the abdominal muscles called a diastasis. And that's also contributing a lot. It can contribute a lot to the shape of the trunk.
Right. So when you look at those patients, I tell patients, and it's so hard, they come in for an examination and here's this guy standing in front of them. It's like every woman's worst dream, right? Is to like, hey, just let your stomach out. Like, just let it all go. Sometimes I sing Frozen song, let it go, so that they'll just kind of relax a little bit and realize that I'm human and I'm not judging them. I'm trying to figure out what's going on so we can get a detailed approach and plan to execute so that they get the best kind of result. But, you tell a patient, and ladies can do this at home tonight. You can do it right now while you're listening to the podcast. You can go get in front of the mirror, take a big deep breath in, and just let it out. And if you see kind of your abdominal shape round, if it's rotund, we're not meant to be that way, right? Like the way that the body is designed is for your muscles to go from the bottom portion of your ribs to your pubic bone. And if they're tied together in the middle, like they are when typically we're born and prior to pregnancies, then that should be flat. There's obviously exceptions to that, but I mean, all in all, we were designed to have a flat stomach. I hate to kind of tell people that. I'm sure that upsets you, but that is the ultimate kind of, that's the vector. That's the way the muscle's supposed to be in order to be at its strongest. That's the way we were made. And so when you separate in the middle, it's the connective tissue. Your muscles are fine, right? There's no damage to your muscles during pregnancies. It's just the connective tissue that holds your muscles in line, that center kind of depression of a six-pack. If you were going to draw a six-pack out on yourself or something like that, that is this connective tissue that you're talking about that separates, that diastasis recti. And so can you go to the gym and get that diastasis recti to go away?
No, you can't. But you can improve the overall
the tone
sure. of the trunk.
Yep.
With exercise, diet and exercise. Those are always the best patients who are already physically fit.
Absolutely. And so similarly, right, an analogy to that would be like, I feel like as a doctor, my posture is getting so terrible, right? And I just, somebody sent me pictures of our Christmas party a couple months ago, and I felt like I was starting to look like a penguin. I was like, my God, I've got to like work on my spinous muscles, my paraspinous muscles, and working on those things. So if you work on those muscles and tone those muscles, then your skeletal frame will change and look better. So if you work on your core, when you're standing there in your bikini or you're standing there in front of your spouse, your muscles are going to be firing. And when your muscles fire, every muscle works by shortening. So it shortens and it will kind of automatically go towards the midline. But the moment you stop firing it, that separation comes back. And so that's kind of when we talk about a tummy tuck, sometimes I'll tell patients a tummy tuck, or I'll use this kind of term that sounds funny. It's dermalipectomy, right? And so the difference between a tummy tuck or an abdominoplasty and a dermalipectomy to me is whether or not I'm doing anything with your muscles, right? So how do we bring somebody's muscles back together from a tummy tuck? Like, where's the incision? What do we dissect? Meaning, what do we separate? So that patients can kind of get an idea of the extent of this surgery. Like they're always concerned we're like going to see their guts. And I tell them, if I see your guts, I'm going to pass out. Because that means I screwed up big time.
Yeah, we did enough of that.
I'm out of here. I'm going to the Cayman Islands and you'll never hear from me again, right? Like we're not seeing guts. We are superficial to your muscles, right? Everybody is skin, fat, muscle. That's just how our body's made. So we are between the fat that's necessary to have a fat layer between our skin and our muscle and the muscle. So where's your incision and where are you dissecting?
Yeah, it's typically hip to hip, but there's different types of tummy tucks. You can make it as small as you need to do to get the work done.
Right.
But
and conversely, right, what I tell patients is as long as it needs to be.
Right.
In order to get the work done.
Exactly.
Right. So, All right. So the incision, we're going to be below your bikini line, your panty line.
Yeah, we keep that incision as low as we possibly can.
Yep.
I mark patients. I have them. When I first see them, I see where their bikini line is with their underwear. And
right.
I use that to mark.
Right. And I tell them to wear, because a lot of people will be like, well, I don't wear a two-piece or I don't wear sexy panties anymore. And I'm like, well, go buy some because you're about to. Yeah. And I say, so wear them, come on in. And what happens is, there's your abdominal tissues get pulled down, but your upper pubic and kind of even anterior thigh, the front of your thigh will get pulled up. Mm-hmm. And we want that force to end up staying within your bikini or your panty line. So I have patients wear that. I have them pull up on their skin to kind of simulate what's going to happen with surgery. And then I'll draw the outline of their underwear, their bikini on them, and we'll keep that incision where it needs to be. Now it has to be a certain distance from the vagina, or it will pull up on the vagina and you get a windblown look to your vagina, and that's not a crowd pleaser for anybody. So there is this kind of no man's
there's
stay
some
out
technical
of space,
details
right?
there that we're not kind of getting into.
We're not just as low as we can go, but we want to keep it in that line. And then you dissect through the skin, through the fat, down to the muscle. You see that muscle layer, and then what do you do?
Yeah, and then you march your way all the way up in the midline to the xiphoid.
Yeah. Which is your chest plate, the bottom of your chest plate and your rib cage.
And then you we call it plication of the muscles, but you're essentially sewing the muscles back together, where they're separated. Typically, most patients, it's a few centimeters that you're bringing together.
Right. Now, I don't ever go extra anatomical, right? Like there's some people I've got a buddy who's a radiologist in Atlanta, and he's just, he'll see CT scans on patients that have had abdominoplasties, and he's just like, the abdominal muscles are all balled up because you're bringing.
Yeah.
I tell the patients, I'm not removing ribs. I'm not doing anything crazy like that. I'm putting you back to where God intended. And if you want to work from that point to work on tightening your abs, getting your obliques in there, you can absolutely, think of the difference you can have without pregnancy, the difference you can get in your abdominal muscles from exercising and eating right and all those things. So you can get that same thing. But what we've done with this plication is we've set that person up to where everything is where God intended. It's right where it's supposed to be. And the rest is some work that you've got to do as well, right?
Yeah. It can look weird when that happens, when people plicate too much, for sure.
Oh, yeah. So I don't do any extra anatomical is what that's called. That means we're going beyond what the anatomy is supposed to be. So I bring muscle edge to muscle edge. People often ask me, are you going to give me a new belly button?
So that is one of the most important parts of a tummy tuck,
right?
In my opinion, and patients too.
But you agree you're not. It's still their belly button.
That's your belly button.
That's right. I'm not giving you a new one. I didn't throw away your old one. And it's a stock that comes from your abdominal wall. It used to house, arteries and veins that kept you alive when you were in utero. And so it stays there. And then we pop it through skin, right?
After we've kind of some patients have a bad looking belly button after a previous tummy tuck from someone else, and we fix that. We know how to, we can make a good looking belly button. You can make a new one from scratch if you need to.
Yeah. And some patients do. You tell them you've got such a bad umbilical hernia or other reasons like that you say, you know what, we're going to do your tummy tuck, and then we've got to make you one. And so that's something that we rarely probably have to go back and just do a neo umbilicus or a new belly button for somebody. But, you're right. What we do is use a special technique to make the belly button look like a normal belly button that has a hood and a ramp. We don't want it to look like a balloon tie or a cat's butthole. Like, that's never good, right? There's so many people who come in and they're like, I don't want my belly button to look like this little slit, because that's not what a belly button looks like. So if we're trying to restore somebody to a beautiful, natural look, then that's what it is, right? So do you ever combine liposuction with a tummy tuck? And what areas do you feel comfortable liposuctioning? And we may have a difference of opinion on this. So I'm uber conservative, and you may be too. But, I always tell patients that a tummy tuck starts with the lower back, and that the lower back hip area is the best place to liposuction. It's the most forgiving skin, which is great. So when patients say, wait, what are you going to liposuction? I say, put your hands up on your hips. And then they do it. And I'm like, what your hands are
your lines.
That's what we're going to. It's taken years. Don't worry. You'll get your own. They'll probably be better. And some of mine are song references that you're too young to know. So, so I say, put your hands up on your hips. And then I say, that's an important component, because nobody wants the front of their abdomen to look rejuvenated and gorgeous, and they've got this muffin top hanging out, right? Like, nobody wants, muffins are delicious, but nobody wants to look
It comes back
at
to aesthetic subunits of the trunk.
Yeah, I stole that line from a friend, by the way.
You have to treat all those areas if you want a harmonious appearance to the abdomen.
That's right. And you don't want, again, we talk about it with all our surgery and with all the providers that do different things. Like, you can have an overdone look. certainly with breasts and certainly with tummies. No, our goal is not to have somebody look like they've tucked their skin into their pants. Like that just looks absolutely horrible. I want you, when you're standing at the poolside or you're standing in front of your spouse or the mirror or whatever, I want the proper amount of skin to be there, the proper muscle definition to be there, the proper thickness of fat, and liposuction is really great for what? For areas that like are just stubborn.
Yep.
And when somebody comes to you and says, I want liposuction everywhere, I'm like, that's weight loss.
This is not a weight loss procedure.
That's not a weight loss procedure, right? Like this is helping sculpting. And that's why we call it like liposculpting. Suctioning just sounds like it's archaic, and it's not as archaic now because we've got different modalities to make it way better. Like, talk about Vaser.
Yeah.
Talk about the power-assisted liposuction that we use.
Topic right now is liposuction, Vaser, all those things. And again, it comes back to blood supply. Right. When we're doing a combination procedure like that, we need to understand that we're affecting the blood supply by doing too much liposuction, and it can affect the outcome.
Oh, absolutely. I mean, when I trained, there were no fly zones. Yeah. And it was like, you do not liposuction above that, where I put my hands up on my hips area, because the blood that's supplying the front of the abdomen wraps around from your back. So if you're starting to do a lot of mid-back, upper back liposuction on a patient, or flank, or God forbid, central abdomen, man, you were going to have problems. And now we've got modalities that have made that safer, right? Vaser, right? And what Vaser is it's an ultrasound probe that we place on, and it actually vibrates at such a fast speed that it shakes the fat away from its connective tissue that surrounds it.
And it bumps by all those little blood vessels and nerves.
So when you're doing Vaser, I mean, it's such a less bloody operation than what standard liposuction used to be. I mean, it used to be you put tumescent fluid in, which was normal saline and some lidocaine and some epinephrine, and then you had this rigid kind of long rod that you'd stick underneath the skin, and it had little offset, holes in it that were very sharp, and it was like grating cheese, basically. And that would leave all sorts of divots in patients, and it got bloody. It got it was almost violent. I mean, it was rough. And then they went to power-assisted liposuction, right? Which is where there's much less of our kind of force in doing it. The actual tip, the cannula, actually kind of moves and makes short little cuts while we're doing long passes. And so that helped things out tremendously. And then the use of the energy, like what we have here in Vaser, has made it to where you're pulling that fat out with almost no effort. It just wants to leave the body. It's fantastic. And you can even do contouring without suctioning after with Vaser. So it's made doing some adjunctive liposuction along with tummy tucks certainly safer. I'm still kind of a wimp. So I tell patients, if you've got some major areas that we need to kind of contend with in the future, we can always do that.
It's always better to stage.
That's right. And it's rare that we have to do that, but we certainly can always do that, right? You can always go do more. You can't rewind time and wish that you'd done less and cause problems. So, mommy makeovers are incredible operations that allow us to restore someone's figure and improve upon their figure, even from where they were prior to having kids. We realize that there's differing degrees, which is why we have differing solutions. Not everybody needs a full tummy tuck with plication and a breast lift with implants. Some people need a reduction or just a lift or just an implant and to reach their goals. Some people just need a mini tummy tuck, which is where we're only addressing abnormalities from your belly button down to your pubic bone. Your upper abdomen looks great. Some people need a little bit of liposuction, and something that I coined. I wish I did some sort of, I wish I'd gotten the patent on it or something. I called it poochectomy. When people have these C-sections and they have that big indentation there because, it's an emergency surgery and It's not always put together in a timely fashion. The OBGYN's not thinking about, is this patient going to have excess skin that I should remove? So, there are differing degrees of ways that we can get the patient to have a flat stomach. If that means we've got to get their muscles flat in order to redrape their skin and subcutaneous tissues over that, well, then that's what needs to happen. Otherwise, you're pulling skin over a round object and it's going to stay round. Mm-hmm. It's just going to be tighter and round, which then looks like you're trying to you swallowed a watermelon or something. So we identify what the problems are. We identify what the patient's goals are, and then we create a solution for these patients and how we can get them to that, right?
Yeah, all the surgeries we do are rewarding for me because patients are just happy majority of the time. But this particular surgeries, I just love to do because they love it.
Yeah,
they're
it
so
really
happy.
is. Yeah,
it restores their confidence,
and it's immediate.
Yeah.
I mean, the first week I tell patients you're going to hate me. You're going to come here for your first post-op appointment. You're going to be like, I don't really like that guy. I thought I liked him, but I don't really like him. And then the second week, they're like, I kind of like you. And the husband's kind of giving you knuckles, or whoever.
Yeah,
and then,
exactly.
And then at 6 weeks, they're like, we just bought a dog and we named him after you. And then, all that kind of stuff. So it's that tends to be kind of what happens with post-operative care. For 2 weeks, it's rough. If we're plicating your muscles, certainly the first week, you're going home and you're staying bent over. Mm-hmm. I send you home with a walker, and it's not because you can't use your legs or anything. It's because I want you to stay bent over to increase blood flow, like what you've talked about in the past and even on this podcast, is we're trying to get good oxygenated blood to all of your tissues so that you heal faster. And so that's the reason for patients to stay bent over for that first week. It's not, I wasn't in any pain. I didn't need to bend over. That's not what it's for. And I continually tell patients.
Yeah, you have to remind them because they start feeling better. And
that's right. That's exactly right. Well, I would encourage all our listeners, I hope that you had a good Valentine's Day, but I would encourage you to email us with questions, any kind of topics that you want us to address in future podcasts, because we're having a lot of fun with this. And I think that it's great. At some point, we're going to bring in a physician that I see that is really great at what she does as far as nutrition, and has helped me lose some weight and has helped a lot of our patients lose weight. Because one thing I will say, and I think it goes without saying, is you want to get in as good a shape as you can prior to surgery, any surgery that you do here. And so patients who aren't ready for surgery or patients who don't hit their goal, it's okay to delay surgery. It's okay to reschedule. Life happens. Things get in the way, and maybe you wanted to lose 15 pounds in 3 months and your surgery's in a couple of weeks and you haven't lost any, or you've only lost 5. But, let's just go ahead and do it. That's not what you want to do.
No, not at all. I'm excited to have her on because that is the topic, hot topic in the country now is all these weight loss drugs. And,
absolutely. Yeah. And we'll talk about all those things. Yeah. I'll talk to you about my personal journey. I think it's been a success so far, and I've been real thankful for that. But we're going to go head to toe on the body. We're going to talk about all sorts of different plastic surgery, and we'll talk about skincare. We've got a bunch of podcasts coming out. I also kind of want to spend some time about debunking some myths. So we'll talk about all these things and give you guys the opportunity to kind of see inside the world of plastic surgery, cosmetic surgery, aesthetics, all of that. So we thank you for tuning in again, and again, subscribe so that you can get access to all these podcasts and know when new ones come out. And we look forward to teaching you all about plastic surgery and in the world of aesthetics. So thank you, Dr. Zoog. I'm Dr. Harper, and we'll see you at the next podcast. Thank you.